Uh, did I just see in the chat, Addie, were you saying you're always happy to co-discuss
I'm always open to co-discussing, but I've done it quite a few times. So if anyone else is interested, they should totally go ahead.
Oh, that was it. I'm sorry. That was a private message.
I think that people is mentioning in the chat that maybe Hans is going to be able to co-discuss. It's going to be able to join us to co-discuss today. Am I correct?
What do you think, Hans? That sounds great. Thank you, Hans. And yeah, everybody obviously can jump in anytime. I know you won't hesitate to in the chat, but please don't hesitate to in by voice as well. Shall we?
Sure, whenever you guys want to. Okay, great. So today we have a 60-year-old male who consults due to fever and chills that appeared around 12 hours ago. And the story is that the patient reports that he was at the airport waiting to board a flight to China when he started to feel very tired. He kind of ignored the symptoms and got on the plane. And during the flight, which was a 13-hour flight, he started experiencing severe general malaise, fever, intense chills. And as soon as he landed in China, he decided to go to the ER.
Wow. Anytime the word airport is mentioned in a clinical case, it's it's sure to be a fun one. Hans, any initial thoughts about this gentleman?
Yes. Our general approach for fever is usually the IMAID and looking at the time course, which is very fast in onset. I would be strongly inclined to start with not necessarily inflammation caused from autoimmune, but from an infection. Now, this could either be something that he picked up somewhere a few days ago with a certain kind of incubation time. So my first thought is, could it be an infection that he got? And then the second thought could be, but less likely, something like an autoimmune, but he's 68. It's not to be ruled out, but it's very unlikely. The next possibility would be something like metabolic, or we could think of something like something like cancer. But all of these things usually require a longer time period, and they don't occur in such a fast onset. So that would be my first approach.
Absolutely brilliant. I totally agree. We haven't heard anything here to pull us away from base rate, right? Not only base rate favoring infection in addition to the acuity favoring infection, but also base rate favoring kind of routine commensal pyogenic infections, right? This is 99 times out of 100, this is going to be, a pneumonia, a UTI, maybe a skin infection that generalized, or an intra-abdominal infection, sort of the bacteria that live in and on us in non-sterile sites that suddenly find themselves in sterile sites and, cause illness. So I'm sure we'll hear more, maybe that will make this a slightly different flavor of that will pull us away from that base rate. But right now we're firmly grounded there, and the rest of the history should be certainly eliciting any signs and symptoms that would support one of those very common illnesses. The other thought I had that I don't know if I've ever had before is like, we think of IMA mnemonic certainly applies to fever, right? But what do the chills do here, right? If these are actually rigors as opposed to just a little bit of chilliness, it's cold in the airport. Does that actually further prioritize infection as sort of an acute within the acute? Not only has this problem been going on for 2 days, but I wonder if some of the other causes of fever tend to make the body create that fever as exuberantly as sepsis does, right? Enough for you to have, to be doing this to trying to skyrocket your body temperature as quickly as possible. And I'm not sure that's the case. I think, I do think that's the case. I think, I don't know if I've ever seen, fevers from malignancy or from autoimmune diseases get to the point of fever via sort of shivering and sort of a rapid increase in the temperature, but I'm not sure. Hey man, is it a good time to keep moving forward?
Sure. Great discussion so far. I'm very excited that you're just laying out a broad scheme to start the case. I'm going to tell you a little bit about the review of systems. So the patient reports that around 4 days before this trip, he felt some type of fever. So he went to his PCP, and the PCP did a workup for that. So he ended up getting a chest x-ray that showed Apache lung opacity. So at that time, he was diagnosed with community-acquired pneumonia, and he was prescribed citromycin. And he hasn't had any other symptoms since he started with that antibiotic treatment. With his past medical history, he has hypertension, but is well controlled. His only medication is losartan. In the history of allergy and surgery, nothing there remarkable. With the social history, the patient is originally from China, and he has lived in the US for over 40 years. He is a college professor. He has a dog that walks daily, and his hobby is gardening. However, he always uses protection equipment for the sun, for ticks, other insects, and he does not use any drugs or tobacco. He does consume alcohol, but just socially.
Thank you, Jimena. Can I clarify one more thing before tagging in Hans? Where in the US does he live?
That's something that came up in the chat. Actually, I don't want to say a lot of information about the case due to HIPAA concerns, but I can tell you that it was on the East Coast area.
Oh, okay, perfect. Thank you very much.
Yeah, I hope that helps.
Yeah, no, definitely. Yeah, Hans, any ideas about this sort of like slightly more I guess or less recent history, the last few days, the X-ray, the antibiotics, and then anything in sort of background that stands out?
What stands out from what we now know is that he has a patchy opacity in his lungs, but only from a chest X-ray. He was given azithromycin for his fever and his chills, or for his discomfort at the early time, but it didn't work. So we have an antibiotic that kind of failed to bring about a change in the condition of the patient. And because azithromycin usually works very well for community-acquired pneumonia, we have to question this diagnosis somewhat. So now we are left with infection or other causes. Now, what I would like to investigate at this point is what is in the lung, and maybe it requires a CT to have a further look at it later on. So now it's wide open. Is it a fungal infection? But it usually it takes a longer time to develop, I think, for a fungal infection. Is it something malignant? Patchy opacity, I really can't tell at this point. Or is it a viral infection, which would not respond to antibiotics either? So we're still open for everything. But our center of gravity, as we would say, kind of is tempted for the lung.
Wonderful. Yeah, I am completely with you on each of those points. Very well said. You know, you use the word only a chest X-ray, and then clarified that, you know, you were kind of alluding to the limitations of just a two-dimensional image, right? And that certainly when you're worried about either whether you're not sure that there was pneumonia at all, or if you're worried about atypical causes of lung infections, or a atypical cause of lung inflammation that may not be infection. You know, the chest CT is a very good friend of ours for definitively imaging the lung parenchyma and potentially giving clues to the pattern of inflammation or involvement that can help us make progress in terms of likely organisms or something that may not be infectious at all. So azithromycin is indeed an acceptable first-line treatment for outpatients with pneumonia. And it does cover most sort of cynopulmonary pathogens that colonize the oropharynx and that tend to cause pneumonia in healthy individuals. You know, but not perfectly so. So sort of expanding on your framework, Hans, that you just mentioned, sort of is it the wrong organism or the wrong drug, or is it you know, not an infection at all, or the atypical possibilities? You know, there are a decent proportion of pneumococci that have developed azithromycin resistance, and there are community-acquired pathogens that cause pneumonia that would be resistant to azithromycin. It's not uncommon to have you know, gram-negative rods and even Staph aureus cause community-acquired pneumonia, whether it's more common in patients who are a little bit potentially older or debilitated or more prone to aspiration, but could really happen in anybody. So I think the syndrome is still one of pneumonia more than anything else. And then the question is, why isn't the patient getting better? In fact, getting worse, despite for first-line treatment. And then you mentioned the entire category of viral causes of pneumonia, which would not, you know, have their own time course and not respond to azithromycin at all. And they constitute at least half of, you know, chest X-ray positive pneumonia in microbiologic studies. So this could still be totally influenza. It could be COVID, right? In addition to bacterial causes that may not respond to azithromycin. I think it's maybe a little too early in the clinical course to consider sort of local complications of pneumonia, things like lung abscess or empyema. But if a few more days pass, or if we had a more certain diagnosis of bacterial pneumonia and things weren't going our way, that would definitely be something to consider. Does anybody, I haven't been looking at the chat, but was anybody intrigued by the gardening at all, or is that just everybody gardens? Depends on how aggressively he's gardening. I love that. Yeah. So people spend time outdoors. A lot of people do. In the Northeast, you know, and actually most places in the US, there's some, you know, some sort of critters that can bite us and give us infections that can actually present in very sneaky ways. You know, in New England, there's so much Lyme disease, there's so much Anaplasma and Ehrlichia, there's babesiosis that often travel together. You know, here in Houston, murine typhus is extremely common, but almost anywhere in the world, there's a species of rickettsia or a similar organism that tends to that can cause systemic disease, of which I have increasingly appreciated the lungs to be apart. And whether that's, I'm actually not totally sure whether that's sort of direct involvement of lung parenchyma with those organisms, or if it's just sort of an immunologic reaction to systemic disease on the spectrum of, ARDS. But it's very, very common in cases of typhus I've seen, as well as in a lot of cases of, leptospirosis and anaplasmosis and Rocky Mountain spotted fever that I've heard about, for there to be essentially like a clinical pneumonia syndrome, in addition to manifestations of systemic illness elsewhere. So I think that that's also in a differential diagnosis, and we should look for a signature of that, of diseases like that, in the pattern of vital signs on exam, in the form of a rash, for example, as well as in the laboratories, in the LFTs and CBC. So having kind of primed ourselves to look for some of those less common causes of a febrile illness like this, let's hear the exam, Jimena.
Thank you. Thank you so much for that discussion. So the patient was with 140/65 with the blood pressure. The pulse was 118, respiratory rate 20, saturating 94 at room air, and his temperature was 39.4 C. In the physical exam, the patient looked tired and sick. He had evident chills, but he was not in acute distress. The oropharynx had no lesions and the neck was supple. He had a regular rhythm and heart rate, no murmurs or gallops heard. In the pulmonary exam, the breath sounds were decreased at the left lung base, but the rest of the lung fields were clear on auscultation. The abdomen was soft, tender, with no hepatomegaly. There were no rashes or any other lesions on the skin. And in neurological, the patient was alert and oriented.
What are we seeing here, Hans?
I would say the exam, especially the pulmonary exam, confirms our finding in the chest X-ray. And now I'm basically have to investigate what is in the lung that causes decreased breath sounds, and it is localized in one part of the lung, which probably might be an indication of more like a bacterial infection than something else. But it is too early to anchor on anything like this. It's just an assumption. Maybe a sputum would help us. Of course, the labs with the WBC and so on might show us one more time that there is an infection going on, maybe with an elevated white blood cell count. So what causes the patchy opacity, I'm still not sure of. My guess it is probably some kind of a bacteria.
Totally. I completely agree.
But it doesn't respond to macrolides, that we know as well.
Right. And by the way, it's only been how long since the macrolides? Okay, four, maybe 3 days. So, we do sometimes get impatient wanting, people to get better when we start treatment, but there's a certain, inertia of bacterial sort of burden and inflammation, right? You don't expect people to necessarily get better right away. But we're getting to the point where it's like, okay, if this was going to be an azithromycin sensitive process, we in most patients would be improving by now. So I totally agree. Hans, would you get repeat imaging at this point? And do you think you would just start with repeating a chest X-ray right now, or would you go straight for a CT?
That's a good question. I think we can skip the chest X-ray because we already have one and go for the much better CT. But we could redo the chest X-ray. It's usually done with a portal chest X-ray quickly in the ER, so it's no loss in time. So why not a chest X-ray and then maybe a CT?
I think either would be perfectly reasonable. Totally agree. All right, let's get some labs. Maybe a sputum, maybe some repeat imaging, or whatever else you have.
You're definitely going to get the repeat imaging. I don't know if you're going to get all the tests that you want right away.
That's okay.
So the white blood cell count was in 14K, hemoglobin 14, hematocrit 40%, and the platelets were 280K. The sodium was 134, potassium 4.1, and his creatinine was 1.06. He also got some bilirubins. The total bilirubin was 2.9, and alkaline phosphatase of 157, AST 160, ALT 205. The albumin was in 3.5, and he also got some coagulation tests, which were normal, urinalysis, which was normal, and he got another chest x-ray that confirmed a lower left patchy opacity.
Thank you, Amanda.
What are you guys thinking?
Hans, are you still processing, or do you want to share? Do you want me
Yeah.
to first? Yeah.
The first thing that sticks out, we have a high white blood cell count, 14K. I would like to see a differential as well. Then we have, and that's sticking out, the AST and ALT and alkaline phosphatase, maybe it's close to normal, and T-bili, which is 2.9. Is this a side effect of the azithromycin because it is metabolized to the liver? Or is it part of the immune of the disease process? I cannot say for sure at this point. I'm more inclined to say maybe it's drug related, but then the next one, yeah. Other than that, I have nothing else to add. I would rather have a sputum or something like this if that could give us some clue.
Yeah, I think the considering a drug side effect and is a great idea. And so often, if we just take a snapshot of all abnormalities a patient may have in a single cross section of time and try to explain all of them with a single diagnosis or a single syndrome, we're gonna fall short, or just have trouble connecting all the dots. So often in real life, the current problem list is explained not by a single process, but by a narrative of one thing leading to another, of one abnormality being the consequence of a treatment or a complication of the initial process that you don't think of as totally related necessarily. So I think the drug effect should always be on a differential for abnormal liver biochemical tests. I'd have to kind of look up how commonly azithromycin causes liver injury. I would guess that it's not like super common, such that if we were sort of weighing probabilities and not just possibilities, and having only two major abnormalities currently sort of trying to connect, the lung process and the maybe liver process, maybe it is still more likely that it is a single unifying infectious syndrome affecting both organs. And as we'd mentioned earlier, and I think I saw maybe pop up in the chat, Maddie was sort of suggesting that this maybe increases the pretest current probability of tick-borne illnesses or sort of arthropod-borne intracellular organisms, like some of the ones we mentioned earlier. So that was the pattern on the LFTs that I was alluding to that did become realized. The pattern on the CBC I was alluding to did not. So what you often see in so-called doxycycline deficient states, which are these arthropod-borne intracellular infections, rickettsial and other, you often see thrombocytopenia, and it's actually a decently sensitive sign, I think, for most, not Lyme disease. Lyme itself doesn't usually cause thrombocytopenia, but I think for Ehrlichia, Anaplasma, and most rickettsia, it's more than half of patients who present with thrombocytopenia. Often there's leukopenia as well, but I think that's a little less sensitive. So we're getting some signals of that, but nothing very definitive. If the chest X-ray infiltrate was on the right side as opposed to the left, would that change anything for anyone? Maybe aspiration. Yeah. The truth is that that right main stem bronchus is a little bit straighter, and there's a slight predilection potentially for stuff you aspirate to go rightwards, but frank aspiration and certainly aspiration pneumonia can happen in either lobe. But one sort of process I was thinking about is a lot of times inflammatory infectious processes in the right base of the lung, of the thorax, can actually sort of track transdiaphragmatically and present with almost an abdominal problem, tenderness in the right upper quadrant, sometimes frank sort of inflammation and even hepatic parenchymal inflammation there, and vice versa. So very often people with cholecystitis or inflammation in the upper abdomen can have sort of pleurisy and splinting and atelectasis as a result on that side, that could potentially mimic a pneumonia if you have an inflammatory sign or syndrome in your body, and then you have opacities on the chest X-ray or respiratory signs. But in this case, there's a disconnect there, so that's more of a tangent, and that's something that applies in this case. I think the other way to try to approach and solve this case is to just kind of tackle one isolated problem at a time, and to sort of think of our framework schema for abnormal for liver injury that in this case is kind of mixed, maybe more hepatocellular than not, and to sort of do due diligence to certainly image the liver, right, to see if there's any focal pathologies there. We don't know what the chronicity of these abnormal LFTs, right, as well as to screen for chronic viral hepatitis and other conditions that could cause the LFT abnormalities that don't necessarily have to do with the febrile syndrome we're dealing with in the lungs. Any other thoughts, anybody, before we ask for more? So just being authentic here, we've been wanting to get some sputum. We've been wanting to check for common viruses. I think with the possibility of atypical infections, a peripheral smear actually has some utility. I think I would kind of want to look at something like that up front as well. And then we mentioned some of the workup for the liver function test abnormalities. I'd also love to see a differential on the leukocytosis hymena if you have that. And yeah, we can kind of pause there for now.
Thank you. Thank you so much for this marvelous discussion. Unfortunately, I don't have the differential, but I hope that you find this case interesting, because this is where the case kind of shifts a little bit, and I want to know what you guys think about it, and of course everybody in the chat too. Yeah. So the patient was covered with antibiotics for the pneumonia, and his fevers were downtrending. However, 48 hours after he developed he developed abdominal pain and lethargy, and he also started spiking fevers again. The blood cultures that were taken at the beginning, as you mentioned, were still negative. He became hypotensive and tachycardic. the new labs that they got, they saw a change in the white blood cell count. It went from 14 to 18. His hemoglobin was 11. His hematocrit was 31%. And his platelets were 310K. However, the CMP remained unchanged. There was only a mild elevation in the creatinine. And then with the bilirubins, they increased significantly to 7. Predominantly the direct bilirubin and the serum albumin decreased to 2.4. He also got a haptoglobin level, which was low. The LDH was 650, the AST was 530, ALT 420, and the alkaline phosphatase 330. He was transferred to the ICU, and his antibiotic coverage was broadened, and he obviously received some supportive care.
Wow. Thank you, Jimena. Our patient is getting sick, is very sick, going in the wrong direction. I think there's a lot of sort of parallel both diagnosis and management that need to happen that you described, right? And the threshold of empirically treating any and all, certainly most possibilities, even if the probability of each is low, has become really important to sort of lower and try to reverse the course of illness as soon as possible. So I think everything you describe was done very appropriately. And we have some additional information. Hans, yeah, any ideas of what to make of both the kind of bedside worsening as well as the laboratory worsening?
Yes, and now looking at the LDH, which is fairly high. I don't know whether we have a ferritin as well, but this and we have hemolysis as well. So something causes the haptoglobin to be low, and an increase, I think, in the total bilirubin, yeah, going up to 7, and the liver function deteriorating as well. So now I think that the opacity in the lung could very well be just a bystander of something more serious. What it is, I can't tell for sure. I would almost do a CT of chest and abdomen, and maybe there are some lung. There is a primary malignancy somewhere, or is it a hematological malignancy, a liquid tumor like a lymphoma? It almost indicates it mildly with the LDH 650. And that, of course, could make the patient very sick as well and make him immunocompromised. The fever could be explained, falls into our IMAID as well. So we definitely need a differential if we can have one.
Wow, fantastic thoughts, Hans. I completely agree that we have to kind of shift our gaze and certainly expand and think beyond the lung, right? That's no longer really the center of gravity of the case. The systemic illness is much more impressive, and then the ALT, AST with the worsening liver injury, as well as bilirubinemia, as well as the drop in the hemoglobin, which is now significant, and coming with an elevated LDH and low haptoglobin, suggesting a hemolytic and possibly intravascular hemolytic process. I was trying to follow some of the comments in the chat, and people mentioning how they've learned that hemolysis doesn't usually cause sort of bilirubin elevations this high, and certainly it should be more indirect than direct bilirubinemia. But if you have a combination of liver dysfunction and hemolysis, certainly the bilirubin can be higher, and the LDH is coming from somewhere. It could be from the hepatocytes, actually, from liver injury, but the drop in the hemoglobin and the low haptoglobin, do need to make us explain sort of and understand what the hemolytic process is, if there is one, because that is a potential sort of pivot point, right? If you have an infectious syndrome with hemolysis, the differential actually narrows significantly. Now, we do have to say that almost any cause of sepsis can cause DIC, right? So in addition to the tests we have now, we want to always pay attention to the coagulation tests in parallel, and maybe I thought fibrinogen to see if there's sort of a global consumptive coagulopathy and some hemolysis related to that. We're not getting that signal here, right? The coags are normal, the platelets are rising. So this seems like this may be a process that is more sort of RBC centric, as well as potentially involving the liver and the lung. So what's our differential diagnosis for infections that can cause hemolysis? We've the group collectively, including in writing, has mentioned malaria. Totally. I think if this is his first travel in a while, he probably didn't get malaria in New England, but the malaria of New England is Babesia, and babesiosis can present very much with everything we're seeing here, actually. Other causes of infectious hemolysis, Clostridium perfringens, I believe can cause a hemolytic syndrome. There's what's the Peruvian or sort of Andean pathogen that causes hemolysis? Thank you, Oreo fever, Andrew. Thank you for that. So there's I'm sure there's more on that list that I'm not thinking of right now, but I think in this case, just with the epidemiology, I would prioritize testing for an empiric treatment of babesiosis, as well as the concurrent infections that are carried by the same tick, and specifically Lyme disease. So I would also do a much more thorough skin exam on this individual. A lot of times the places where we get bit by ticks are sort of dark moist places where people aren't used to looking. But I've seen erythema migrans appear in the popliteum, in the groin, on the back. So it's important to kind of look in some of those places where we don't routinely examine patients. What's going to help us make progress most rapidly? And by the way, beyond the discussion we've had, again, just sort of being systematic about every problem, anything else we should do to work up the hemolysis kind of in a more systematic fashion without anchoring on just infectious causes? Or the presumption of hemolysis. Okay, yeah, Hans. So blood smear. What else?
Because we should see Babesia in the red blood cells. Then I would do a Coombs test.
Yeah.
And
totally.
maybe an electrophoresis, a protein electrophoresis, just for completion, but it doesn't get us too far, I suppose.
I like it. I think the two biggest things we're missing right now that we shouldn't do without is looking at the blood smear, and then looking for sort of immune hemolysis, which is just a very common cause and can coincide with causes of systemic illness in the immune category, right? That can also affect the liver as well as the rest of the body. So okay, I think we've had a good discussion. Jimena, what comes next?
This has been amazing. You're gonna get some of the tests that you have been asking for a long time. And just to let you guys know that this is gonna be the last aliquot before I reveal the final diagnosis. So because of the lethargy, the patient had a CT of the head, which was negative for hemorrhage, mass effect, or infarction. We did get the sputum cultures that you were asking for at the beginning. They were negative. He also had a respiratory viral panel, which was negative, including COVID. We also got an HIV testing, which was negative. Viral hepatitis was negative too. He got testing for Lyme, Anaplasma, Rocky Mountain fever, Q fever, Ehrlichia, and all of those were negative. And we did get a reticulocyte count that was in 2.3.
That's the end of the aliquot.
Yeah.
Love it. So Hans, so how do you interpret that reticulocyte count?
I would say it is elevated. So I can almost say the bone marrow response, at least to a certain extent, I would say it is elevated, the 2 point something.
You know, I'd have to calculate the reticulocyte index, but for the sort of correcting for the degree of anemia, my gestalt is that there's not quite an adequate reticulocyte response, which I'm actually kind of surprised by, especially if this is and was a hemolytic process. You know, it may have been going on for some time. The hemoglobin being normal initially can actually represent compensated hemolysis, which is, you know, referring to the fact that if you have a normal bone marrow and adequate stores of iron and folate and B12 and everything like that, you can lyse some red blood cells, but then make enough to not even become anemic until, of course, the process gets fast enough or you run out of some of those resources to make more red cells. So, yeah, so I think if this was an acute hemolytic process from Babesia, for example, I would have expected a little bit more of a reticulocytosis. That being said, whenever you have systemic illness and inflammation, you also sort of develop certain reactive compensatory mechanisms that impair hematopoiesis, right? So, you know, I'm sure this person's ferritin would be elevated and their hepcidin is upregulated, and maybe that is a sort of getting in the way of making new red cells. But I'm talking a little bit theoretically now. So we have to make a diagnosis now. Hans, where do you think does the answer lie? Does the last aliquot of information we got argue against our top hypothesis from the last data set?
Well, it excludes many of the infections that are possible. It does not exclude yet Babesia, but as you mentioned, it should show probably a little bit of a higher retic count. So if I assume that something is in the bone marrow, and it could be just at the very beginning, which mitigates or lowers the reticulocyte or the response somewhat, but not quite, I think a blood smear, where we look at all the blood components or the white blood cells, etc., might give us some insight of what is going on. And I'm tempted for a liquid tumor, which I cannot yet identify, but it could be CLL, it could be anything possible, even a lymphoma. And all of these can reside in the bone marrow, go for the liver, and cause these symptoms with fever and infection-like signs. Of course, we could also go with a bronchoscopy for the patchy opacity, but that's too invasive.
I totally agree with you, Hans. Like, I think there's still a differential here, and I think for further exploring the possibilities of neoplastic disease or autoinflammatory disease, you know, there are hematologic malignancies. There are processes like hemophagocytosis reacting to whatever that could present similarly. There are other infections too, like certain herpes virus infections, you know, certain presentations of EBV, CMV could manifest similarly to this. But I think the one infection we've considered that we haven't yet ruled out, and that is most aggressive and most rapidly fatal, as well as fitting both the syndrome and the epidemiology most closely, I think is still babesiosis. So that would be my best guess here, and that's what I would still want to kind of look for and treat first before moving on to less likely things.
So are you guys ready for the final diagnosis?
Yeah, we're ready to be humbled, Jimena. Thank you.
I think that you have done a marvelous discussion. You're not going to be humble at all because you got the correct diagnosis. The patient got Babesia antibodies which were positive, and then he got a peripheral smear that revealed parasites that were consistent with babesiosis. He had around 9% of erythrocytes containing ring forms. And I just want to give a big shout out to Maddie because she cracked the case in the chat. Because the interesting part of this case was that the patient had received azithromycin. And that's why we thought that this presentation of babesiosis was so not characteristic. And just to give a little bit of background, when you treat babesiosis, you use azithromycin and atovaquone. And this patient had an incomplete treatment. And as it happens with a lot of parasites, you need to cover them with 2 medications to actually be sure that you're eradicating. And especially Babesia, that it's a difficult parasite to eradicate, you need to recheck the peripheral smear of patients to see if they actually have 0% of parasitemia. That's how you know that the treatment worked. So yes, this was the case. I loved the discussion. I love that the chat was on fire, and I love how you guys always pay attention to the smallest detail, and that's what gets you there.
Wow, what an amazing case. Thank you, Jimena. That was great journey. Hans, your comments, your thoughts were just amazing. Just I think spot on at every turn, and I'm curious if you have any reflections about the case or kind of favorite moments or teaching points.
Yes, we started with fever and chills. We didn't know whether these are rigors. We worked them out as well. Then we saw something in the lung, which made us think at first that something could be an infection in the lung, like a pneumonia. So we investigated this one. We had to realize that our antibiotics didn't work. So in that case, why? It's an antibiotic. Then the physical exam kind of corroborated what we saw in the chest X-ray. And then the liver function tests and the deterioration of the patient while on antibiotics with a decreasing red blood cell count and an increasing white blood cell count made us think that it should be something else. And we had basically a malignancy or hematological malignancy versus babesiosis or other infections that could affect the blood and causing hemolysis. And we didn't do a blood smear at that time, but with the blood smear and the antibodies, we found that this was a very humbling case indeed. So I thank you very, very much.
Thanks, Hans, for joining us and your great discussion again. Yeah. Tansu, Jimena, we'd love to learn a recap or any other pearls from y'all.
Thank you so much, Jimena, for finally getting rid of our curiosity. Now we can go on to live our day contentedly after learning the end of this case. So I have some teaching points I will share with you guys. We started off with a 68-year-old male with fever and chills. And when the patient had fever, we invoked our I-made mnemonic, and the time course being acute and the base rate of infection being more common than other possibilities, we thought, oh, could this be an infectious process? And then we said we should look for other signs and symptoms in the history to support these causes. And then the patient had chills, and we questioned if these chills are actually rigors. And this would further prioritize infection because rigors create a fever exuberantly, like we see in the case of sepsis. And fever secondary to other causes can get to the point of shivering, but not to the extent of rigors. And then we saw patchy opacity on the X-ray of the patient from his prior visit to his PCP. And this patchy opacity was thought as pneumonia, community-acquired pneumonia, and treated with azithromycin. But the patient was not getting better, he was getting worse. And in such cases, we always think, are we treating the wrong bug? Are we using the wrong drug? Is there resistance to the antibiotic that we are using? Or is this a source control issue? And other possibilities are atypical causes of lung inflammation, infection, malignancy, and viral causes that also make up 1/2 of the cases of chest X-ray positive pneumonia. So we thought that the center of gravity in our case was lung, but then it turned out, no, the lung was not the center of gravity actually. The gardening in patient's history made us think of outdoor bugs, and the patient, having lived in the US East Coast for a while, made us think of the epidemiology of some bugs such as Babesia. And this was the highest on our differential actually towards the end. And then Ehrlichia, murine typhus, rickettsia, and all the other outdoor bugs. And then the pulmonary exam also tricked us to think that the lung was the center of gravity. But we thought that if azithromycin was the right drug to treat this process, the bacterial burden and inflammation would go away slowly and the patient would have improved by now. So maybe we should get further imaging at this point, and we thought both chest X-ray and CT could be reasonable options here. And then as the case unfolded more and more, and Jimena shared with us the chemistries of the patient, we saw that he had elevated LFTs, which had mixed hepatocellular pattern. And we thought, could this be a side effect of azithro, part of the disease process, or another cause? And then we focused on the lung process and liver process being unfolding together in this patient, and we searched for whether if there was a single unifying syndrome or not. And we were getting more and more. Our suspicion was getting more on the side of the arthropod-borne infections because of the elevated LFTs. But we also said in such cases, we would also expect thrombocytopenia and leukopenia, which were not present in this patient. And then worsening course of infection in this patient was more focused on the liver and had a systemic signature. Then we decided that lung opacity was no longer the center of gravity and it may be bystander to the liver process. And then from the elevated LDH and low haptoglobin, we thought that there's an intravascular hemolytic process going on. And then we thought about the infections that cause hemolysis, such as malaria and Babesia, Clostridium perfringens, and Oroya fever. And then the hemoglobin being normal initially, we thought, oh, maybe the hemolysis was compensated initially. And if there was an acute hemolytic process, then we would expect higher reticulocyte index. An addition of the impaired hematopoiesis now because of the low reticulocyte index made us think that maybe there's an infiltration of the bone marrow secondary to a hematologic malignancy, granulomatous or mononucleosis type infections or Babesia. And again, the pretest probability of Babesia was getting higher and higher because it was fitting the epidemiological picture and the clinical syndrome that we were seeing here. And then finally, the peripheral blood smear nailed the diagnosis. And Jimena shared with us that babesiosis is treated with azithromycin and atovaquone, but it's such a persistent, stubborn infection that we gotta recheck the blood smear after the treatment to make sure that we completely eradicated the bug. That's all from me.
What a journey. Thank you for helping us go through it again, Tansu, and thanks Mariana for the great scribing. Jimena, finally we've jumped off the cliff with parachutes on, and it was an amazing free fall. Thank you.
Thank you all for everything. I really enjoyed presenting cases, and I think that's something important that came up in the chat that I kind of forgot to mention was that this patient did have the habit of gardening, and he was very well aware that he needed to use protection for ticks due to the area where he lived. So he was very well educated in that matter. But unfortunately, he didn't use protection to walk the dog. And he mentioned that sometimes he liked to go and play with the dog in the garden. So that's how we think that he might have gotten bitten. And it just shows that when you already have like an idea of what it can be, a diagnosis in mind, like it's just a matter of asking and being like a little bit persistent with patients for them to explain what these things mean to them, because we might assume that they're doing things in a certain way, and it can actually change and just guide us more towards one thing or another.
Thank you, Jimena. Thank you, everybody. Hope y'all have a wonderful week. Bye. Hey, Jimena.
Yes.
Will you remind me? I'm sorry. What do you do, and where are you now?
Well, I am originally from Guatemala. I am here currently. I just finished medical school. I graduated this year, and I'm applying for this cycle of the match. And I am super interested in internal med, as you might guess.
Yeah,
Yeah.
it was. I would have guessed. Yeah, that's great. It's nice to meet you. Yeah, hope to hang out on Zoom soon again.
Nice to meet you too. And thanks, Hans, for jumping in and discussing. I always like to see your comments in the chats on VMRs. I think that they are very brilliant. And I do want to tell you that I like that you always kept the diagnosis very broad and also consider malignancy, because it was a possibility looking back on how the patient presented. But that's something that when I saw the case, I never thought about it, but it was a good teaching point for me too.
Totally agree. All right, John. Take care.
Bye.